So the legislative space around privacy and information setting is quite a complicated one on the surface, because there's lots of different pieces of legislation that have something to say about this, and it can be confusing to be kind of faced with, Privacy Act, the Privacy and Data Protection Act, the Health Records Act, and think, oh golly, what are we supposed to do? And the result can kind of be like, well, I'm just not really going to think about it because it's all a little bit complicated. I guess on top of the legislative requirements, which I won't go into, is that health professionals and other practitioners have their own kind of professional obligations in relation to privacy and confidentiality. So we've got the Privacy Act, which is a Commonwealth piece of legislation, and that applies to all organisations that have a turnover of more than $3 million. Organisations that are providing contracted services to the Commonwealth Government, and private sector healthcare service providers. It doesn't cover state government agencies, including public hospitals or healthcare facilities. Then in Victoria, we have the Privacy and Data Protection Act, and that covers Victorian public sector organisations and private or community sector organisations that are contracted to provide services for or on behalf of public sector organisations. Makes sense? And then you have the Health Records Act, which covers private and public health service providers and pretty much anyone any organisation that holds healthcare information. So is there anyone in this room that thinks that they don't come within one of those pieces of legislation? No. Some of you probably think I come under multiple sets of that legislation. And the good news is that they're largely consistent, particularly in terms of what we're discussing today around use and disclosure of personal information. So the principles across the different pieces of legislation are fairly standard. And there's some additional stuff in the Health Records Act, and I'll also touch on briefly the Mental Health Act, because that has, again, some additional provisions around sharing information, particularly with carers and with family members. So the general kind of, each legislation has its sort of principles around privacy. The Victorian legislation, which pretty much would cover most people here if you're dealing with health information, comes under the health privacy principles, and they're like stuck on at the end of the Act, and you're obliged to comply with them. So you mustn't disclose information about an individual for a purpose other than the purpose for which you collected it. So that's the basic rule. But there are various ways that you can move beyond that, but that's where you start from, that I have this information and I shouldn't be disclosing it or using it for a reason that's not why I got it in the first place, which for healthcare will be to provide healthcare services to a person. If you're a housing organisation, will be to provide housing. So then there's a couple of exceptions. So the first is that the reason you're providing the information or sharing the information or using the information is related to the main reason that you're providing it. Like it's an integral part of what you're doing. And the person whose information it is would reasonably expect that you would share the information with that person. So within a healthcare team, in a service, a person would expect that you would share information with other care providers in that healthcare team. A person who's given permission to have a referral to a specialist from a doctor would reasonably expect that it's connected to the reason that you've given the information, that there would be some information provided to them. So that's one exception. Another exception is when there's kind of serious issues of risk of harm to an individual's, the wording is life, health, safety or welfare, or a serious threat to public health, public safety or public welfare. So in those kind of, sorry, my mouth has completely dried out. In those kind of emergency situations where there's some serious crap going down, then there is an exception provided under the Act. The main way that you get around this requirement of the Act is with the consent of the individual involved. And that is, I should have started with that one because that is really where you should start. If the beginning and end really should be consent, unless there is an inability to get consent and there's some other kind of issue taking place. So those provisions come across all those pieces of legislation. The Health Records Act has a further exemption if someone doesn't have the capacity to consent. You can give information to an immediate family member where it's necessary to provide appropriate health care and the disclosure is not contrary to any wish that the person has previously expressed. So in a situation where it needs to happen, you've got an immediate family member there, the person is unconscious or perhaps in such a state of unwellness that they're not able to provide that consent, there is a limited exception to share the information. But really, I can't stress enough that the most important thing is consent and that it really should be the exception that you're looking for ways around it. Even that idea of a secondary purpose and is it connected to the... If you've started with consent, you don't need to tie yourself in knots about is this reasonably connected to the reason we've got the information. You just know what you're doing and you've had a clear conversation at the outset or prior to passing on information. Now, the Mental Health Act has some additional kind of exemptions to this requirement where information can be shared. So there's kind of two layers of it. There's some disclosure that can be made, and it says in general terms, so not very specific information, to a friend, family or family member or a carer. So the Mental Health Act sort of anticipates that there's some way in which you can share some information. This is for prescribed mental health services only, who are covered by the Mental Health Act. But it can't be if it's contrary to the views or the preferences that have been expressed by that person. So if the person is saying, there is no way I want my mum to know about this, and the mum is not a carer of that person, then you can't just go and share. But there is a sort of additional layer. If the person is a carer, then there are some additional kind of, not really exemption, but a way of facilitating information. And that is if the disclosure is required, reasonably required, by a carer of the patient to determine the nature and scope of the care to be provided to the patient. And you've had regard to the person involved's preferences and views about sharing that information. So it's different kind of requirement. The person might say no, and you can have regard to that, but you don't have to necessarily comply with that. But you've also got to be careful of where you're drawing the distinction and that the person is actually a carer under the Carers Recognition Act, which is quite clear to say that just because someone is a parent or a child or living with the person or the partner of the person, that is not what makes someone a carer. They have to be in a care relationship and the person needs to be providing care. So you have to always take, I guess, a nuanced approach and consider who it is that you're wanting the information. So there's kind of two issues that obviously are on the agenda for today, but there's that intra-agency or intra-professional sharing, and then there's the sharing with carers and family members. And the principles cover both. Consent should be the driving force for each, but particularly when we're looking at carers and family members, there can, in the mental health context, sometimes be a different approach. And I think this stuff is really important to people. I think it's important to comply with your obligations under the legislation because there are consequences to that, and that people can make complaints to the Healthcare Complaints Commission. But more than just it being a legislative thing, it's about the trust that is built with the people that you're working with. And we see it a lot in our service. We have people calling up our night service. We are an organisation that works with consumers of mental health services. And a lot of the calls that we get are about my information has been shared without my consent. And it does undermine the relationship of trust that I think is essential to be able to provide the services that people need. And I've seen a case just yesterday, and I can see Robert here today, where a lot of information has been obtained and shared with family members, and it really has created kind of a big mess. And I think there hasn't been a sort of stepping through of who these people are and what role. There are also avenues you can take to make sure that if there are family members that people want to be involved, that is clear to everyone. And under the Mental Health Act, we have the ability to have nominated persons who have a role throughout different aspects of the Act. The other is, I guess, a healthcare decision maker, those kind of options. So if you've got family members who are wanting to have an ongoing involvement, advanced statements is another way that people can use it for one way or the other, to say these are the people I want involved in my care, or these are the people that I do not want involved in my care. I'll finish up then because I don't know. I'm happy to take questions, but I guess I would just stress again that consent is, in my mind, the beginning and the end of it, for your own protection and for the protection of the relationships that you're trying to base your work upon. So hopefully I haven't totally confused you.
Does anyone have any questions of Anne?
Okay, my name's Naomi Chapman. I work for Victorian Transcultural Mental Health, or VTMH, and I'm a consumer consultant, which means basically I've got a lived experience of engagement with Victoria's mental health services, the public system, and I use that lived experience to help inform the work that we do at VTMH. So we help people build capacity and hopefully reduce inequities within the mental health service. Before I begin, I just thought I'd reflect on the Uluru Statement from the Heart, which is pictured in this slide, and just has some interesting points about diversity and people's responses to it. As you probably all know, 3 years ago, Indigenous leaders came together to release this statement, calling on Parliament to take a number of steps forward. The statement outlined the path for recognising Indigenous Australians in the nation's constitution. It asked us to change the constitution to allow Indigenous people a voice in the laws and policies that are made about them. Unfortunately, government leaders in general rejected the statement. Some willfully misunderstood parts of it, and they dragged their feet on taking any action. So I just wanted to kind of reflect on this, because if our first response to issues of cultural diversity is dismissive, where do we go from here? There's not much room to negotiate. Okay, that's just VTMH if you want to check out our website. We've got some free training resources on it, and modules vtmh.org.au. So during this talk, I'll share some underlying principles regarding privacy, confidentiality and information sharing. I'll then look briefly at some policies that back up these principles, and then move on to specific mental health scenarios as examples. And obviously when I talk about those examples, I'll do it through the lens of being a consumer. So in brief, privacy and confidentiality are long-standing issues within the mental health sector, and they have an extensive impact on the relationships between consumers, carers and clinicians or workers. As you all know, in the 60s a movement began to deinstitutionalise Australia's mental health system from a primarily paternalistic focus to one that's more human rights based. A few decades after that, in the 80s, mental health consumer advocacy began due to a need to advocate for the awareness, protection and understanding of mental health consumers. And one of the most fundamental rights was the right for consumers to be able to choose when and how information about their mental health was to be disclosed or how information sharing was to take place. There's an old saying in consumer circles, nothing about us without us. In recent years, the phrase has been gathering resonance for consumers. It has advocated for a greater role for consumers in their healthcare treatment, rehabilitation and or recovery. Okay, that first point is really critical, and I was interested in the first speaker's point about consent being really critical from a consumer. And I just wanted to make the point that obtaining consent is not a sort of a one-off thing that you do and a tick a box. It's actually a dynamic process. The consumer's view on what is happening to them and their needs are likely to change with time, requiring continual negotiation between the person and the worker who's trying to help them. So, most community service organisations do have policies and procedures that help regulate privacy and confidentiality of client information. The concept not only applies to what you can disclose about your clients or your organisations outside of work, but also what can be shared within the organisation. So as the other speaker mentioned, organisations need approval to disclose or to share a consumer's personal information, but if there's a serious threat to someone's safety or well-being, for example, that consumer's consent may not be legally required. So just going back to that first point about obtaining consent being a dynamic process. In the early days of a consumer's engagement with a service, they may be floridly unwell and be having difficulty remembering even simple instructions. Under these circumstances, and if there's no other directives such as an advance statement, the worker may choose to give greater weight to his or her own explanation of what's happening psychologically for the consumer, and that may mean that the medical model of mental illness may be given priority in that case. I just wanted to stress before we move on that it's important that even under those circumstances, attempts are made to give the voice to the consumer's explanatory model and, where possible, to accommodate this. For example, a consumer might at a particular point in time favour a spiritual explanation for what they're going through. The worker could then make suggestions to accommodate this and perhaps look at some interventions such as the person joining a religious organisation or a church. I'll now look at some of the specifics around confidentiality and information sharing in practice, and I'll spend a few minutes looking at issues around how to help consumers in mental health settings. As mentioned in the previous slide, assuming and then establishing that the consumer has the competency to make decisions is critical when looking after their mental health, particularly when shared decision making or collaboration between workers and the consumer is the goal. Competency forms the basis of shared decision making, and it enables the consumer to give informed consent to their treatment plan. As the slide says, a worker can encourage shared decision making by asking the consumer questions such as, what information do you need to help you think about this situation? Or how should we write this up? So it's a collaborative process. The consumer's capacity to understand and respond to what is happening to them in a constructive way is at the heart of shared decision making. And while capacity may be negatively impacted for a period of time, often all that is needed is for the worker to frame the session differently. For example, they may need to first address issues of pressing concern to the consumers, such as paying rent or feeding a pet, to establish trust before moving on to their mental health. And we know shared decision making is really important, as it can create a new relationship between individuals and professionals that's based on partnership. Consumers in general want to be more involved than they currently are in making decisions about their own mental health and healthcare. So, in addition to the desire for basic human rights such as privacy, there are many further reasons for consumers' frustration at information sharing that occurs without consent. I'd just like to make the point that sharing the wrong information or too much information can be damaging to relationships, and the first speaker emphasised that really nicely. Relationships that we're talking about can be either therapeutic or between consumers and carers, and they can be negatively impacted. Any short-term advantage that can come from acts of coercion or deception, not that, in an ideal world those wouldn't happen at all, but if they do, they can create barriers that patients and service providers experience for a long time to come. Ultimately, consumers want to move on towards more humane and person-centred care, and shared decision-making is a really critical part of that. So I'll just end there.
So, I'll give you a bit of a rundown. I'm a social worker. I'm a project worker at Nexus, dual diagnosis. I'm a clinician at the Bouverie Centre. I'm a community member on the Mental Health Tribunal. But what I'm here today to talk to you about is actually the most important role I have as a carer or a mum of a son with dual diagnosis. That would have to be the most challenging, time-consuming, distressing role that I have, an unpaid role that I have. So I'm going to talk to you a little bit about my role as a carer. And I guess the main thing I want to get across to you today around confidentiality and sharing of information is around ask, don't assume. And that's been our experience over 14 years of dealing with dual diagnosis in services. I'm just going to tell you a little story about a recent experience that I had, which was almost 3 weeks ago, around privacy and confidentiality. I'm going to read because I'll go off track. Okay, sorry. So I recently spent the most part of 5 days in an emergency department and short stay unit in a hospital with my son who had dual diagnosis. He was having seizures and they tried to discharge him twice, but he kept having to come back within 24 hours because he would have more seizures. It was an interesting experience. I sat next to his bed, which was opposite the nurses' station, because they had to watch him for every time he had a seizure. There are a number of staff changes over the days, as you can imagine, a number of handovers. Handovers were held in the nurses' station, and after every 10 minutes, there'd be another handover of the doctors. So they had the nurses' handover first, and 10 minutes later they had the doctor's handover. As I sat next to his bed, I was able to hear the handover that was going on and taking place. Handover not only my son's case, but also of all the other beds around him. I knew the lady opposite had stomach cancer and there was a plan to tell her. The lady next to her had a broken back and they were deciding what pain relief to try, as she didn't like taking pain relief. There was a young girl in the next bed who'd taken an overdose of her mum's Seroquel, and I knew all the details about her mental state. I got to hear the psychiatric assessment by the doctor. So I knew she'd broken up with her boyfriend, went to work, came home, was distressed, and in an instant decided she was going to take her mum's Seroquel. I knew exactly what she was thinking at the time. I got to hear my son's handover. Talk about Chinese whispers. The story varied, sometimes significantly, from person to person, even though his actual condition didn't change in a particular shift. At one stage, one nurse came to my son's bed after handover to introduce herself, and I had to correct the information that she'd been given about why he was there. As you can see, there was absolutely no privacy, no confidentiality. I get that it's a busy environment, ED and short stay, and people are coming and going all the time. That doesn't mean their respect and dignity shouldn't be respected. Also, if someone was doing a psychiatric assessment of me in a cubicle with just curtains around, I'd be guarded. And it wouldn't be a symptom of the illness, it would be because it was about privacy. So that was just a recent experience, and sometimes we just fall into a habit of just talking openly and not being aware of the environment that we're in and who's in that environment. That was a recent experience. So I'll move on from that and just talk to you about what it's like to be a carer and the sharing of information. So as we've heard, there's legislation that governs what information is shared and to whom. There's also the Carer Recognition Act, which was incorporated into the Mental Health Act in 2014. And the Act talks about providing, the Mental Health Act talks about providing information even without consent, where it directly impacts the caring role and relationship. And I guess what I would like to emphasise is the care relationship and the importance of understanding who is in a care relationship, who are those people. And a care relationship is not just about what someone physically does for a person, and the Act tells us that. It's also about emotional support. Many family members or carers don't live with the person, and just because they don't live with the person doesn't mean there is no care relationship there. My son now lives in a different state, but I still get 2 to 3 phone calls a day. There's still the financial support, and there's all the liaising with the services in that other state that need to happen. If I put it for a moment, my clinical hat on, the best way of understanding relationships and a care relationship is to do an echogram. Some of you might know them, social workers, where you can sit with a consumer, with them in the centre of the actual echogram, and get them to point out who are the people in your life, and you can see the relationship, the distant relationship. You know, it might be the dog, although that's not a care relationship, but that might be the most important relationship. So the actual consumer gets to tell you who the most important people are in their life and what that relationship is like. It's a good conversation piece to have. Okay, I'll put my carer hat back on. Ask, don't assume. So if you're not sure who to share information with, ask. Just because someone's over 18 doesn't mean they're independent, or they should be independent, or want to be independent. Ask the patient or the consumer, or ask me. If I'm with him, ask me as well if I want to share information. And if sometimes as a carer, I won't want information shared with the consumer. So be mindful that there's more than just the consumer's privacy and confidentiality at stake. There's also the carer's confidentiality as well. I've found having that conversation in the first meeting is always good. Having a communication plan or a strategy open, transparent about what you're going to share. So I go to a lot of appointments with my son, especially first appointments, because of his mental health and his anxiety, and he won't be able to walk through the front door. So I go with him to those appointments. So I'm often there. And I always ask for a communication. How are we going to share? What are we going to share? Most carers don't want to know what's discussed between the consumer and the clinician. They just want to know what they have to do to support the person, or, you know, if there's appointments, where they have to drive to, or those sorts of things. They don't want to know the ins and outs of duck's bum, so to speak. It also helps make the expectations clear of what you can and can't provide, what you will and you won't do. Having a clear communication strategy. Don't make assumptions or judgments about the relationships. Just because I'm asking lots of questions as a carer doesn't mean I'm over-involved, enmeshed, or that we are dysfunctional. My son's 28, and after every conversation he has with a clinician, or whether it's by phone or whether it's in person and he's left, he'll say to me, "Now, what did they say? What did they talk about? What was their name?" He doesn't remember things because his ability to take on a lot of information isn't there. So I'm not asking to be intrusive. I'm asking so I can support him. Understand that you can take as much information as you like from a carer. You just can't give it personal information. So if someone was in hospital and this carer keeps turning up saying, "I want to speak to a doctor can take information. They can't necessarily give it without consent. And a lot of people get that mixed up. A carer often just wants to give a handover, just as you do when you change treating teams or services or anything like that. A carer wants to be able to hand over the information that they've got so that they feel the clinician knows what's going on and they can step back, and you'll find it's a better relationship because they trust you. So that's really about that. The impact of caring on a carer or not, and of information sharing. Carers often assume services talk to each other. And as service providers, you know that's not always right. And it's really frustrating for a carer, as I assume it is for you clinicians, when you realise that a service provider doesn't have all the facts and they're sort of working blindly. My son has a housing worker and she didn't know much about his mental state at all, and we assumed the clinical mental health service was liaising with the housing people, and they weren't. But nobody had asked him whether they could. We just sort of assumed, and he assumed, and it didn't happen. Often, when information isn't there, it's left to the carer to fill in the gaps. And then we come back to the carer's over-involved, the carer's enmeshed, all the rest of it. But often that's around information sharing. Again, from a carer's perspective, when you first meet, ask the question, who do we need to communicate with? Who is involved in supporting you? And revisit those questions over the episode of care. He might be really pissed off that I've put him in hospital, and he doesn't want anyone to talk to me. As he gets better, that will change. So keep revisiting that question. Also, if you don't talk to me, I can remember times when my son's presented to emergency and the first line of call is olanzapine. If I'm not there, how do I know he can't have olanzapine because he has dystonic reactions? I can't assume that somebody's read his file. I can't assume that they've asked him or he's in a state to answer. I can't assume it's even written in the file from a previous admission, because services don't always talk to each other and share information. So the not sharing of information has a really big impact. So carers hold a lot of information, so just ask them what they know. You don't have to disclose anything about the consumer or anything that the consumer's told to you. You're allowed to do that. That's my carer hat. If I put on my professional hat and just talk about the difference between a nominated person and a carer, it is significant. And I don't advocate for carers to be nominated persons. A nominated person under the Mental Health Act is there to represent the interests or advocate the interests of the consumer wishes. How often do we hear carers have a different view than the consumer? And I know when I sit on the tribunal, we'll have carers come into hearings and the treating team are there and the consumer's there, and the treating team will say, oh, this is their nominated person, pointing to the carer. And I say, well, are you here as a nominated person representing the consumer views, or are you here to tell us what you think as a carer? They are completely different things. So be aware, if you're advocating for someone to be a nominated person, think very carefully about whether a carer should be that nominated person. A carer can still get notified. If you register a carer on the documentation that there's a carer, any mental health tribunal documents that there is a carer, that carer will be notified. So it's really left up to the clinician to put it on the forms, and just, rather than say no carer, write their name on and they'll be notified. They don't have to be a nominated person to be notified of a hearing. And just picking up on another point that you said, if someone's under the Mental Health Act, is a compulsory patient, I believe they have more rights to their information than if you're not on under the Act. Under the Act, a compulsory patient has the right to have access to their file 48 hours before a hearing. So they can read through their file, their solicitor can read through a file. If a person is not under the Mental Health Act, they don't have that same right. They have to apply through freedom of information. It's a bit weird, but that's what's written in the Act. So just also being mindful of that and what you're writing in files and the way you write things in files and the views. And I guess also around carers and their views. It's around setting up, the communication and what you write. When I'm working with a family, I always tell them that I'm going to write in a consumer file, and together we work out what I'm going to write. So there's no, that needs to be FOI'd and all this sort of stuff. We've had that conversation before. That's about all I've got to say. So, thank you.
So, thanks for having me. I was just thanking Naomi Carter for titling my the final piece of today, the final presentation, as Best Practice. Just as I am uncomfortable with grand titles, I'm also uncomfortable with owning anything like best practice. But I'll give you some insights into what I've had experience with in relation to information sharing, particularly where there's cross-disciplinary, multidisciplinary, multi-sector, multi-paradigm meetings of minds, where it's gone really well, and also where it's gone really unwell. It's not so right in a mental health forum, is it? I mean not south, where it's gone south, although I am from Tasmania, so that also is a little tricky. Before I begin, I want to pay my respects and acknowledge the owners and the sovereign owners and custodians of the lands on which we're meeting today, the Wurundjeri people of the Kulin Nations. I want to pay my respects to elders past, present and emerging, and to my respects to any Aboriginal and Torres Strait Islander people with us today. And I was thinking about that acknowledgement in the context of information sharing, and one of the things that strikes me, and particularly in relation to people navigating the mental health systems, the alcohol and other drugs sector, the primary health, allied health, and in my context, the legal and justice systems, that this conversation wouldn't be so pertinent if there wasn't a keen sense of vulnerability and disadvantage. Certainly in the context of acknowledging the sovereign owners of the lands on which we're meeting today, Aboriginal and Torres Strait Islander people are far overrepresented in all of the sectors that I just mentioned then. So I want to make that point really clear, that we're actually talking about something that is based in the context of privilege as well. So, that being said, what I want to talk about today, Naomi said to me, "Elisa, you're so much better when you just get up and improvise, when you're spontaneous." And I said, "But I've prepared." And then we had these amazing people, the Anns and the Naomis and the Lyns of the world, get up, and I thought, oh great, well that's first of all, a tough act to follow, and second of all, I don't want to present on anything I prepared so diligently. I actually want to pick up on some of the things that they all mentioned, and because they're really worthwhile. But first of all, to give you some background, for those of you who don't know me from a bar of soap, I have worked for a really long time. I started out in the not-for-profit world. I started out working in youth health, specifically in drug and alcohol, down in before mentioned Tassie, in the very south of Tassie actually. I don't mean Dover, I mean Hobart. For those of you from Tasmania, you'll understand what that means. For those of you who don't, I'm sorry for the obscure reference. So in Hobart, where I was working in youth health in an AOD context, where we had a needle and syringe program, where we had young people that were coming in who were rough sleepers, who were disconnected from all sorts of pockets of community, and their mental health was pretty undesirable. I think the thing that connected them was a sense of belonging and a sense of safety. And the relevance to the conversation today about information sharing, again, comes back to that sense of safety. And I think it was Lynn and Naomi who were talking very strongly about the concept of trust. And even when Anne, you were speaking, you were the conversation in terms of consent was also is also a really important, really blithely in the health sector, in anywhere you work, we all have our consent forms. Who doesn't have a consent form in their organisation? Exactly. And you all write them out diligently, right? And then you've probably got policies as well now that say, 3 years ago even, you probably wouldn't have had a policy that said you have to update it every 12 months. Now everybody's got a policy that says 12 months you have to revisit it, or at least if you don't, maybe get it in there. And the reasons for that are for exactly the things that Anne was talking about in terms of, and actually for that matter Naomi and Lynn, in terms of being able to account for change of circumstance, and also to not just, it helps the practitioner to not just blithely go, yeah, we've got consent, we'll just talk to whoever we want. It brings us back to a mindful reason for sharing consent. And I think in some of the conversation that happened after the previous three speakers, some of you were talking about the concept, Kevin, I think it was you that said the most important question when you're going to share a piece of information is why? Why am I sharing this? What is the possible outcome of me sharing this? So in the question that you had about what happens in terms of ringing up a person, making a referral, and you know, for example, that somebody's not travelling so well, and that they're that in your organisation, in that context, that person is presented in such a way that means that you've put some greater risk strategies in place than otherwise you might have. How do you, when you're making that referral, do you have a duty of care to the other organisation to say to them, hey, this person's not travelling so well, you probably want to double up, and let them make their own inferences? Or a duty to warn. We were talking about that at the table as well, and this extraordinary, for all of you people who have either taught or have just been through subjects, courses like social work, and you've gone through ethics and the law, and you've found out duty to warn and Tarasoff means something to you. Well, you know, the Tarasoff refers to a person in the United States. We were talking about the extraordinary thing that we've got in a piece of American case law that defines what we do in Australia, which doesn't have any defining link in terms of legal frameworks to what we do here. But without the clear understanding of what duty to warn means, it starts in our day and age of risk management and very, very low risk appetites and low risk acceptability thresholds. We start applying that all over the place in a real overly high wielding way. After I left Tassie, I came into, well, actually, while I was still in Tassie, but also what brought me to Victoria to call this place now home was my involvement in the drug court. So I'm a social worker by trade, and I came into the justice system because I wanted to work with the people that everybody else absolutely said, no, not working, not touching with the barge pole, because of the risk that you were talking about and because of the overlay of fear of the forensic client. How many of you work with forensic clients? Yeah. So I wanted to work in that space. But as a health professional working in a justice system, the irony is that our confidentiality and the information sharing that we do is so largely and tightly dictated by a legal framework, and yet when you go to court, so all of the people that put your hand up to say that you've worked with forensic clients, it's presumably because they've got court orders of some kind. And I'm willing to bet that 8.8% of the people that you're working with weren't in a closed court situation, which means that at any particular point, you could go down to the corner of William and Lonsdale right now, sit in Court 1. Court 1's a great court, and Anne will attest to this. It's very busy. Anne and her duty lawyers probably hate it, detest it, because it's such a busy court. But you can find out pretty much anything you want about a person just sitting in the back of that court. You can go upstairs to level 4, and similarly, in fact, you'll get even more information because that's the therapeutic courts, and none of them are closed either. You'll get a few questions if you walk into the assessment referral court list. That's the mental health court, so very relevant to this context, depending on which magistrate's sitting behind at the bar table, because they don't sit on the bench in that court. How many of you have been to the ARC list? Okay, so did you not put your hand up, Anne? My goodness, just the record. So depending on which magistrate's sitting behind at the table, they might look up at you and say, what's your business here? Because they are acutely aware of the sensitive information that gets discussed in that court. But if they're busy or if they're not minded to it at the particular time, you can walk in, sit at the back of the court, listen to all of the things that Lynn just listed about all of the people sitting around in their bedside in that very open environment, and it has exactly the same impact and exactly the same effect. And if you happen to be a journalist sitting in there, you have absolutely free rein to write all of that stuff down as well, because it's on the public record, because as a person who is in the criminal justice system now, you've just lost pretty much all your rights to confidentiality in that context. If you know how to work the system, you can find out a whole lot about people, and you don't have to have signed a consent form or have one to be able to show. You can just rock up. It's terrifying. And the reason for me that that's so terrifying is that I always come back to, and I've always, with any of the teams that I've worked with or had the pleasure and the privilege of managing, when I say pleasure, not always, but mostly the pleasure and the privilege of managing, it's always been a privilege. I have always said, at no point should you ever blithely decide on a whim that somebody's personal information is yours to be able to share. Unless it is actually yours to share, then you must always ask the question, why and what impact is that going to have on the other end? Because coming from the context that I work in, when information gets shared around, and actually it's true in the primary health system as well, and even worse when you're up against the tribunal. I mean, God, I wouldn't want to sit in front of Lim, by the way. Can you imagine how scary that might be? It's a joke, Lynn, it's a joke, but it's all right. We've got Anne sitting by our side, so she'll back us. But we've got, we're in a system where I've lost my point because now I was imagining being in front of the tribunal. The point is, because where we sit in the context of the criminal justice system or the mental health system, or even in the context of the guardianship board, or in VCAT, in any place that where Anne was talking before, and I wrote it down because I wanted to make sure. So the exceptions and the exemptions to the law for information sharing that Anne referred to, you can correct me if I'm wrong, serious risk to life, health, safety or welfare. I mean, I don't know that there's any specific definition of what serious risk to health, life, safety. So there isn't something defining that in the Act. So it's very much up to interpretation. My interpretation for somebody who has been criminalised, and the place that I work in now at Flat Out, every woman that we work with has been criminalised. Every woman that we work with would have, if you were sharing information without really thinking about what and how and the language that was used to be able to share information, would be at potentially serious risk of safety, of their welfare, and consequently of their health, and consequently potentially of their life. Because the sorts of levels of damage and impact that you can do by inadvertently sharing something for somebody else to interpret, and that's the other important piece to this puzzle as well, is that it's not just you sharing information with all your good intentions, it's how that person on the other end receiving it interprets that information and then applies that interpretation. That could cause serious harm to somebody. And to anybody, particularly though, where you've already got the stigma and the history of a criminal background and of a criminal record. So, where I've seen it work well, gosh, I don't know if I'm talking about best practice, am I? But nevertheless, hopefully it's useful. Where I've seen it work well, so in the drug court setting, and this is something that we talked about in preparation for this conversation today. In the drug court setting, as I said, we've got multidisciplinary teams sitting around the table. It's obviously led, a conversation is chaired by a magistrate. Already that's pretty potent in terms of, good luck to all of you, depending on which magistrate it is. When they ask you a question and you say, sorry, Your Honour, I'm not prepared to answer that, I don't have a signed confidentiality waiver. There are some that will say, oh, good point, Miss Buggy, thank you very much for that. There are most who won't. I'm sorry, Miss Buggy, but remember where you are, this is my court, this is my chambers, I will hear from you. And unless I'm a lawyer and I have the legal privilege, I'm kind of obliged to say, okay. Unless I stand my ground really firmly and say, no, not going to, subpoena me. You've got that available to you, by the way, but just so you know. Nevertheless, it's a very, very hard thing to do. So I'm saying that to give you the context of the what I'm about to describe, which is what we were talking about in preparation as a place where information sharing tends to work better. But there's a caveat at the end, so, spoiler alert. So we've got a magistrate, we have a lawyer, Victoria Legal Aid, we have a Victoria Police representative, they're now police lawyers, but we used to have a prosecution team admin person there. Nevertheless, Vic Pol. We have people from Regen and Odyssey House, so social workers, counsellors, case managers from those organisations. We have community corrections officer, community corrections officer? No, that actually is their title. Community corrections officer and housing support workers at the table, and also a registrar taking notes diligently, recording every piece of information that gets discussed around the table, and when it's on a court file it absolutely stays there. So and in that space everybody has already contributed to a piece of paper that says this is the drug results for the last week of the person. So when you're in a drug court, you get tested 3 times a week, those drug results come up. Then it talks, everybody around that table, bar the lawyer and the prosecution team, all contribute a little blurb for every week about a person and how they've travelled in that week. And there's all sorts of precarious language used that make the terrain really, really tricky to navigate. And so one of the things that is the most important to build in that space is not only trust with the participant, that is extremely important, and a little bit of a tricky tightrope to walk, because you've also got somebody providing consent in a coerced environment, right? So, in terms of consent, what does that really mean? Is it freely given? I'm not sure. But, that's a question mark I will leave out there for all of you. And then we have, so not only trust with the participant, that you are first doing no harm by this process, but also trust with it within and between each other, that if you're interpreting something in a way that doesn't look the same, it doesn't look as though it was the way in which it was intended, that you will ask, that you will have that open conversation, and that when you're delivering information, that that I'm trusting you to have been so diligent and vigilant in the use of your language that there is no room for misinterpretation, that it is extremely clear, and that it is always coming from the basis of unconditional positive regard. How often do you reckon it happens, though? Look, it does happen, of course, and one of the things that is useful in a court context, apart from the fact that you've got the imprimatur of the court, etc., the authority of the court, but you can be sure that everybody has signed their life away to get into a drug court or onto the ARC list or into a KISS program. They will have signed the bail conditions, the sentencing order, the consent to share information, etc., etc., etc. It used to be the case, and this is the spoiler the thing I was alluding to when I said spoiler alert. It used to be the case that what would happen in a drug court was a participant would turn up, and of course, lives are complex, right? And they become even more complex when you've also got, when you've been charged and found guilty of something, of offending that is so serious in the magistrates court context that it warrants more than 3 months imprisonment. So, we're not talking about, easily navigatable worlds in that space, in that sense. But so complex lives. I'm not really comfortable with that, speaking of language, but anyway, it does the job for this purpose. And that includes Department of Health and Human Services child protection. So many people in the drug court have come across child protection space as well. They also they also have intersections with family violence. Who here is a prescribed agency in terms of the family violence information sharing new legislation? Right, so all of you now are now, regardless of the conversation we're having right now in terms of information sharing, all of you that have just put your hands up are obliged, if I pick up the phone and invoke my right as part of that piece of legislation, to gain some information and from you about somebody who has been identified as a perpetrator or somebody of potential risk of harm to somebody else, must tell me, including the police, including all sorts of people. And I don't have to know where you're coming from, except to say that you've just said that, as under the Act, section blah 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 blah, that you must tell me, and now I sign myself off. But what about in the case of the women, many of the women that I work with, who have been misidentified as the perpetrator of family violence, for example? So the case of an applicant, of a person who's picked up the phone because they're fearful of their life or risk to health or self, or any of those reasons. They've called the police have turned up. I've gone into shock. I'm not particularly coherent. In fact, I'm probably not acting in the most sane and functional way that I possibly could be. But the person who has just been extremely violent to me, who also has a scratch on his face because I was trying to get them away from me as they were coming at me, and I happen to have long nails. They say, "See, officer, look at Elisa. She's completely crazy. She's gone off her head. She's thrown, look at this house. The whole house is a mess. You've got to get her out. I'm really, really scared. You've got to get her away from me." Officer says, "Yeah, that looks like the case. Come with me, Elisa." Off we go. I'm now the perpetrator, and you now have to, with any ramp process or person who's working with my partner who's actually enacted the violence, have to share all that information. And then then the person that's then my partner now knows everything about me and can use that against me. So what I'm trying to say is, in fact, I kind of deviated off what I was alluding to before in terms of a drug court. And so what I want to finish with is this. In that drug court setting now, there's been a practice direction. A practice direction is something that the court can issue. It's not part of legislation, but it underlies legislation in terms of the direction of the court, so it forms a structure. It's like your policies and procedures, you know. There's a practice direction that says that when you come into the drug court now, when you sign to say that you're accepted onto a drug treatment order, you also sign to say, and while I am on the drug treatment, while I'm on the drug court program and on a drug treatment order, I consent to sharing of information to anybody that the drug court team, all of them, deems appropriate to support me on the drug court program. Words to that effect. So the reason I was talking about child protection earlier is because it used to be the case that if, in a drug court, as I said, you're tested 3 times a week. That's also really interesting if you've got child protection involvement. Child protection really want to hear about the tests that you are providing. They also want to know if you're really not travelling so well mentally. They also want to know if you're not travelling so well just generally. And they will take that information and they will interpret it as they see fit. And in the context of drug court, all of the consent and the things have all been collected. They're all in place. They're all the I's are dotted and the T's are crossed. And what that means then is that there is the potential, even though in that drug court team nucleus, the information sharing is absolutely paramount to supporting the person through the process and has had enormously fantastic results for the people that it's worked for, absolutely without a doubt. And that's because like Lynn made the point, that's because people are talking to each other. Even the doctors are talking to the social workers, which is just unheard of. And I take your point, you know, and it works like a dream in that respect. But there is this broader world, and so there is always a yin with every yang. There's always an up with a down, and so. So I just urge you all to be really conscious of the implications of sharing of information, the extraordinary benefits that it can have for supporting somebody who doesn't and shouldn't have to constantly tell you about their story, you and you and you and you, because you can't get it together to do a case management coordination session, you know. That's on us. Where it's not, where it strays into being really unhelpful and in fact putting somebody at high risk of life, health, safety and welfare, is where we forget to ask why and we forget to ask what are the consequences. And that, in my view, is best practice. To remember to ask why and to remember to ask what for, and to remember that with every single piece of information that you're sharing that isn't yours, there is another person for whom it is, and they really matter. That's all.